Thank you so much, Dr. Alvarez. And I'd like to invite the panel to all come back on video for our question and answer session. And as the questions come in from the audience, I just want to get started on one question that came up for me as I heard folks talking is, for a number of different communities that you were talking about and in general, as well as different settings, the idea of kind of issues with measurement and not having sufficient research and not having visibility within research can come up, whether that is within pediatric populations and kind of the challenges within there, forcibly displaced folks with Dr. Sadi, LGBTQ communities, within research and genetics for sure, and kind of getting people engaged in that research. I was wondering, maybe we'll start off with Dr. Sadi and we can kind of go around. What are some issues with that measurement, with kind of how we include folks in research?
Yeah, thank you for that question. So I think in terms of forcibly displaced population, oftentimes, asking about refugee status or asylum status or immigration status is typically not asked. And especially sort of neglected from national data sets. Having said that, the thing that I think is important to consider, particularly with forcibly displaced populations, is the real harms that can happen when we don't think about, who's collecting information, why it's being collected, who's going to be shared with, what sort of shared decision making is involved in terms of how information is disseminated. I can think about in the context of the pandemic, for example, we know that there were cases of public health agencies who were sharing information of people who tested positive for COVID, with including names and addresses, with law enforcement, right? And that can sort of contribute to fears and real fears that people have in terms of sharing information sharing between across sectors. So I guess my one point to sort of make it contribute to into the discussion is that it's really not as simple as let's just get more data. And I think oftentimes when we have these conversations, we sort of say that without the added next steps of thinking about, okay, well, what does that actually mean? What is going to be done with that information, and how are we going to mitigate the real harms of this information potentially getting into the hands of wrong people and contributing to disparities that exist?
Dr. Blatt, would you also like to comment on that question?
I think, some of what we're thinking about in terms of inclusion and thinking about sort of the pieces are going to be asking about sexual orientation, gender identity, sex assigned at birth, focusing on some of the best practices, looking at your healthcare environments, making sure people are hired appropriately, and thinking about I talked today some about the historical but current concerns. So I think it intersects with health, mental health, some of these key pieces. And as I mentioned, we need research as well, right? Most of our work doesn't even ask about people's identities and a range of identities. We know that these intersect, right? So I think that we have a lot of work to do. We're starting to see the evidence in terms of disparities in access to care, disparities in terms of health concerns around these neurological conditions. And so my hope is that if we can all make a commitment to moving the field forward and asking appropriate questions, hiring people from our community so that they can represent our groups, we can start to make advances in sort of addressing the concerns. But a lot of our speakers highlighted amazing tips and advice on doing that. And I think all of these we need to be considering. Yeah.
Yeah, Ms. Highsmith, you actually mentioned kind of the diversity of the workforce too, right? I didn't know if you wanted to continue with this question.
Well, I think for us to diversify the data, the thing that we have to do is, I can't say this enough, we have to be trustworthy. And in order to be trustworthy, you've got to go out into the community where people are. They're not going to come to us. We have to go to people. We have to build external coalitions and partnerships with the community, and you have to do it over time. And so for Black and Latinx communities, that means what I call the 4 Bs. You need to be in the bodega, the barbershop, the bishop, and the beauty salon. That's where the conversation is happening. That's where trust is being built. So as people in healthcare, and for me, us in research, in order to have a conversation with people, we've got to meet them where they are, because the healthcare system, to the point, if you're giving people's names and who has COVID, like, that's not building trust. No one's going to trust you. And so in order to be seen as trustworthy, and because the other thing I think is we've got to stop blaming these marginalized communities. We've got to stop blaming marginalized communities saying, well, look, they don't want to participate in the research. No, it's not that they don't want to participate in the research. We haven't proven to be trustworthy, and we haven't explained, what are we going to do with your data? For instance, for us, while we do turn our information into the FDA for clinical trials, it's de-identified. So we need to share that information with people. Grandma can participate in the clinical research in oncology, and little Bobby ain't going to be found out about nothing that he might have done. And people see on TV, you hear all these stories, well, somebody did an ancestry test and now they have found somebody else. We've got to explain that in healthcare and clinical research, that is not going to happen, that the data is protected and private. And so getting in the community and speaking with the community and answering those questions is what is going to get us the opportunity to get more access to data.
Dr. Alvarez, in your work, what issues do you come up with in terms of identifying kind of or measuring or doing the research in your communities?
Absolutely. Well, I think everything that has been mentioned is extremely relevant to work with youth and families. And the two pieces that I would add in terms of measurement are that measures need to be developmentally appropriate, and often they're not. So we're applying things for adolescents that are developed for adults, and they're not being answered the same way. And often we're not surveying younger children at all, for out of the perception that they're not able to be surveyed or it's not possible, when really there's a lot of great data that you can get. And the other piece is the multiple informants. And so parents and youth can have very different perspectives on what's going on. Parents may not be aware of the particular challenges that youth are facing. Youth may not have disclosed, their experiences to parents. So part of the problem is that we'll often have, maybe national surveys that are being done in a phone interview with parents, and we're not actually getting the data on how the youth themselves are impacted or what concerns they see as being most important. And the last piece I would say that comes up is the idea that we don't respect youth's perspectives for what they are. And so you will have a situation where youth do express to adults, for example, what they think the concerns are, what needs to happen, and adults will then, respond with, oh, well, you're just worried about that because, you're young, or, oh, that's not that big a deal. But it is a big deal and it is important. And so that kind of knee-jerk response often to diminishing the youth perspective or to putting it within an adult framework when rather than seeing it from their point of view can really be a challenge sometimes in advancing and being able to actually build on youth ideas.
We have a question that came in from the audience that I think ties into this really well, is in talking about kind of the workforce and diversity of the workforce and kind of ideas of going forward. The question is, what is the role of academic or medical institutions in training neuroscientists, neurologists, or psychiatrists who are prepared to embrace intersectionality of their patients? What changes in graduate or medical education are needed? And I'll open it up to whoever would like to respond to that.
I'm happy to start. I think it's great looking at the curriculum. I have seen some studies that assess around, let's just, around LGBTQIA plus curriculum and exposure. How many times have there been case studies or even sort of the mock clinical encounters that identify these issues? So, and most of the curriculum, I would say most of the training does not address enough, right? We heard, right, building trust. that should be like the first part of sort of the training, is how can you build trust with your patients or with your participants in your studies. But thinking about the intersectionality piece, thinking about some of the best practices. But I think also the huge piece is around training people around their own implicit biases and how they bring that to their work that they do, to understand that and really dedicate their time towards cultural humility, that ongoing openness to learning. And so that should be a part of all of our educational curriculums. So that would be my
Let me double down on what he just said, because I think one of the changes that we must really make is that these scientists and clinicians, they are not critically trained on D&I issues. And there is so much data that is out there that shows that they desperately need it. There was a study looking at children up to age 18 that went into the emergency room for emergency appendicitis, and the Black children routinely did not get any pain management. They let these kids suffer. And 96% of the white children who went into these same emergency rooms, they got comforted, they got the pain medication, they got quick service that they needed. And so training and education around systemic racism and why discrimination is, how it is institutionalized and embedded into these systems, has really prevented communities, Black, Indigenous, people of color, LGBTQ, from getting the type of access to care that they need. And we need to double down on ensuring that there are pathways for many of these first generation college students, many of these students that have to maybe work 2 or 3 jobs, so that they get access to the same career opportunities and pathways that others get, so they can be scientists and physicians. And it's more than just saying, I'm gonna contribute to an HBCU. It is, how are all of us in this audience, what are we doing to engage, to ensure that we are diversifying medicine and the science?
I'll add on 2 additional points, which I think maybe is more like pitfalls around how to address this. I think one is we really need to be addressing health equity from the outset rather than as an add-on issue. And I think oftentimes this happens in medical education, where you'll have all these, lectures about all these topics, and then you'll have this one add-on lecture at the end that's about health equity, right? And I think in the same way, when we think about our research, right, it needs to be integrated at the outset. There shouldn't just be the separate mechanism for just health equity related projects, right? Health equity should be integrated in every project, every research project that's done. How are you thinking about this, right? Every lecture, every research, it should be thought about from the outset. And I think the other thing that I see as a potential pitfall that I think we need to be proactive about addressing is sometimes these issues are sort of seen as, just pertaining to this particular individual who represents that community, right? Oh, okay, we have this Muslim woman who's coming, she's going to address Muslim American issues. We have someone who's from the LGBTQ community. These are, their issues to deal with. But we have to really reframe it as being everyone's issues to deal with, right? Then it shouldn't just be, okay, we've checked off this box, we have an individual who's coming, and it's going to just be on their plate, but it should be on everyone's plate. And so just thinking about sort of 2 pitfalls that I often see in this work in medical education and also research.
And I'll follow up on that to say that from the research, perspective, I think one thing I'm always struck by is that there are always, when you're working in academic medicine and health disparities, there's always students, medical students, residents, fellows who are interested in these topics and wanting to build research in these topics. And then there are so many barriers that people encounter to getting funding for this work, even to just having their work received in a work in progress meeting positively. It can be a really difficult and lonely road for people. And then, you end up being pushed to other areas. So seeing that level of enthusiasm and seeing how that's impacted, as well as just the idea that we constantly have to go back to the beginning and make these points, right? So if you're curious about why people of color are being pushed out of the medical field, there's tons of documentation everywhere from the academic literature to social media posts to op-eds that people have documented their stories and why it's happening. The information's out there. There's nothing that we need to find out about why people are being pushed out of the pipeline, but there's constantly this sort of going back to the beginning and asking why, right? And I think the points that have been made here today, we have the information as to why, and it's addressing that racism, that discrimination in the pipeline that is necessary to make a change in this.
That ties into another question that we got, which was focused on disparities in low birth weight for folks, and particularly Black and Indigenous and people of color, and kind of ongoing disparities despite improvements in maybe income and access to more education. There's still these disparities that exist, and I think we can tie that into CNS disorders as well, right? Where there's persistent disparities that exist despite potentially some improvement in some of these social determinants of health in some structures. And the question is really for anyone in the panel, despite some of these improvements, there's ongoing disparities, and thinking about the lens of access to care being part of this bigger picture, bigger component. We've talked a lot about this, but can folks really think about other issues and other barriers that folks are experiencing, even with maybe some improvement in some of the social structures?
Well, I'll jump in to say, I think that it's very much the story of health disparities, right? The idea that these issues have been identified for decades and they persist, and we're not seeing improvement in many areas. And it does seem to be, a combination of this real challenge with addressing issues at a systemic level rather than an individual level, that it's not about individuals having access to the care, but it's about all the other things that happen either before they get to care or once they're there, how they're treated. So this issue of addressing things systemically and of making large enough investments and big enough programs, we see that, for example, children's economic outcomes, drastically improved in terms of the number of children that were living in poverty due to the child tax credit, program, and then that's taken away, right? So we haven't had investments really in maternal and child health, for example, at the level that we would need to really be able to see any kind of reduction in disparities. And a lot of programs, are happening at too small a scale to be able to see that impact that we would want to see.
I'll weigh in here. We have to stop pretending that there's real objectivity in healthcare, right? This is a mask for homogeneity, which assumes that everyone goes to the hospital, the Black mother goes to the hospital, and she's going to get the exact same treatment that everyone else gets. It's not true. I remember during COVID, there was a Black physician on staff in Indiana at the hospital who had COVID, was hospitalized, told them she was not doing well, was dismissed, sent home, came back with severe symptoms, and ultimately died. This is a Black physician at that hospital on staff. And so patients of color are not believed. When we say we have a concern, it is not taken seriously. And so the medical community has to really listen and not assume they know what's better than what the patient is telling them. There's numerous, Serena Williams, famous billionaire, had similar issues when she was having her daughter. She was not believed. And luckily, somebody came in and was her advocate for her. But this is happening every day. So imagine if you are not you don't have the economic means, what happens to you if well-known women are having issues and they are not believed?
That's such an important point. And I want to thank all of our panelists. Unfortunately, we are at time. I feel like we could discuss this all day and still come up with new and interesting ideas and thoughts for the future. But there is a second part of this, so stay tuned. I will pass it back to Dr. Hurd, and thank you again to all of our panelists for your brilliant insights. Thank you.
Thank you all. I agree. This first session was really outstanding. I appreciate the candor and the important topics that were addressed. And we're going to continue this discussion about access to care in about 5 minutes. So just give everybody a few minutes to stretch their legs. So we'll see you back at 1:05. Thank you.